Our next speaker, who will talk about mitral valve interventions and more about the mitral valve click, is Paul Sorajja. He's the director of the Structural Heart Disease and Valve Program at the Minneapolis Heart Institute, and we are very fortunate to have you here today. Thank you for coming all this way and getting out of your cold.
Oh, thank you. I gained 40 degrees by coming down south, so this is good. It's actually -7 tomorrow in Minneapolis, so no complaints about the cold here, okay? So I enjoyed that talk by Dr. Hastings. He's right. He's actually the most important person in the room when it comes to these procedures. We like to look at fluoro, but you just can't do it. You have to be humble and have the echo person tell us where we are. And so those slides are beautiful and also very informative. So anyway, I was asked to talk about mitral valve interventions. And when we look at mitral disease, we know a lot about TAVR. And I guess you could think, well, isn't mitral disease just a sequel to what we've done for aortic valve stenosis? Well, I think most of us know that sequels can look quite similar, but often are not the same. So if you take these movies that were made by Arnold Schwarzenegger, on the surface, they can look quite similar, but we know the plots and the box office gross has varied quite widely. And I would tell you that MR really is not a sequel when it comes to comparison to aortic stenosis. The mitral valve is inherently complex. There are leaflets, there are chordae, there are papillary muscles, there's also the left ventricular walls, and as a result, there are multiple etiologies for MR, multiple therapies, as well as multiple outcomes. And not to compound this further, but when you look at the patients who have MR in the United States today, there are actually 4 million people who have mitral regurgitation, and right now there are about 30,000 of them who have surgeries each year, and so there's an underserved, unmet clinical need. And that need represents a number of challenges that only compounds the complexity for managing these patients. So let's talk about two therapies that have helped with addressing some of these needs. And Dr. Hastings has already shown you in depth one of those therapies, and that's the Mitral Clip. This is a 24 French transvenous system. It goes up from the right femoral vein and crosses over to the left atrium. And thus far, as of last summer, there actually have been over 25,000 people who have received Mitral Clip worldwide. And for those of you who do this experience or do this procedure or are interested in this experience, since October 2013, this has also been commercially available in the United States. So much like what you just saw, these are examples of a patient who had Mitral Clip. So on the top left-hand side is a patient, once it plays here, with severe mitral valve regurgitation. Is due to degenerative mitral disease. On the top right-hand side, we've crossed over across the mitral valve. We then pulled the clip up against the leaflets. At that point, these gripper elements, they're also called friction elements, are dropped. And in the bottom left-hand side, we create this tissue bridge or double orifice, which then, over in the lower right-hand side, leads hopefully to a reduction in the mitral regurgitation. And you can see here, comparing this patient in the lower right-hand side versus the upper left-hand side, this was an excellent echocardiographic result. So I had the pleasure of looking at the first report of Mitral Clip in the TVT registry, and these were presented at the ACC last spring as part of the late-breaking clinical trials. And this paper is actually published in the Journal of American College of Cardiology. And in summary, we looked at 564 patients, and this is the initial commercial experience in the United States. Indeed, these are high or prohibitive risk patients. Mean STS was 10%. And this is MR at baseline versus post-implant, and thankfully, 93% of these patients had a reduction in MR to grade 2 or less. And if you looked at grade 1 or less, that actually was 64%. And these changes in MR were significant in comparison to their baseline. And also, thankfully, was that these procedures were accomplished with relatively low adverse events. So if you look at the in-hospital mortality, it was 2.3%. Remember that the STS predicted mortality in these patients, if they went to surgery, was actually 10. We define procedure success as reduction in MR to grade 2 or less without surgery and without death, and that occurred in almost 92% of patients. Complications, half of which were bleeding, almost 8%. I think one of the remarkable points of this study was that the length of stay was 3 days, and 82% of these patients went directly home, with another 10% actually going to an extended care facility. So over 90% of patients avoiding a nursing home after hospitalization and going home over to extended care. Now, these data are also favorable when you compare them to what's been reported elsewhere. So these data are at the top, and you can see here, looking at European versus Asian registries, the patients who are being treated in the United States tend to be a little bit older with more DMR as opposed to FMR, but the success rates with Mitral Clip are comparable across the different etiologies, and the adverse event rates also are quite low. And when you compare them to the preclinical research study, the results are also quite favorable in terms of success rates and adverse event rates. So that's Mitral Clip. I'm also going to talk about transcatheter mitral valve replacement. Now, this is another frontier in cardiology and cardiac surgery, and there are a number of different valves that are being studied out there, really too many to count, to be honest. It's very hard to keep track of everything that's going on. But what I want to do is I want to start by talking about some of the challenges with TMVR that are out there. So the first challenge with TMVR is that these devices, they're all high profile. And these devices in their current versions at least, when you overlay them, there's a propensity to cause LVOT obstruction. And an example of this is if you look on the left-hand side here, this is a patient who was referred for TMVR in our practice. And when we're doing these procedures, we take the prosthesis and overlay it on the CT image. We then do cross-sectional images of the LVOT, and we find the narrowest point. And that narrowest point is called the neo-LVOT. And that area measured 114 square millimeters. And anything less than 250, at least in the current limited experience, is going to be something that's going to predispose a patient towards LVOT obstruction. So this patient on the left-hand side was turned down for TMVR. Now compare that to this patient here on the right-hand side. This patient, LV is obviously more dilated, the LVT is larger, and the neo-LVOT here was measured at 612. So this patient on the right had TMVR in our practice, the patient on the left did not. And I think you're going to hear more and more about neo-LVOT, whether it's TMVR or mitral valve and valve, or even potentially surgical valve placements, because surgical valves can also have high profiles depending on the anatomy of the patient. Now the second challenge with regards to TMVR are the pressures in the left ventricle. And these pressures, while we think of them as normal, they're not trivial. And they also are not trivial when you compare LV versus LA. So if you look on the left-hand side, this is a left ventricular systolic pressure of 130. And there's also a left atrial pressure, a waveform there for your reference. And if you calculate that pressure applied to a mitral valve area, the pounds per square inch is about 2.51. Now to put that in perspective, if you look at the launch rocket of a Saturn V rocket, 33,000 kilonewton thrust applied to a 49 by 41 meter launch pad, and the pounds per square inch of that Saturn V launch rocket is actually less than what's applied to the mitral valve with each heartbeat. So trust me, I did this calculation at least 30 times to make sure this is right, and I'm happy to share that derivation with you. What was that, Matthew?
I'm impressed
Yeah.
that you can do those calculations.
Well, it took a lot of SI conversion units, but I did it 30 times, I promise. But you know, the point of this is not really to brag about the left ventricular pressure on the mitral valve, but it's really to talk about, again, that these pressures are not trivial, and they have implications for the anchoring of these devices, which is going to require a lot of strength for them to stay in place. The other implication of that high pressure is that PVL may mean more in a patient with TMVR rather than TAVR. So this has to play after I forward through everything here, but if you look in the upper left-hand corner, this is a surgical valve with PVL, and it doesn't really look that impressive. But when we go in and measure the left atrial pressure, you can see here that this actually is an impressive hemodynamically significant PVL. Now, certainly there are differences in compliances for the left atrium versus the left ventricle when we're talking about PVL of the aortic valve versus the mitral valve. But in my practice, I do believe that PVL significance is easily underestimated, and I do a lot of perivalvular closures, and the vast majority of them happen to be mitral. And I think most of you who see that out there would agree that most commonly, mitral PVL is the most common reason for closure. So we'll finish by looking at one technology, and this is the valve that's currently been most commonly implanted currently in the United States. And this is the Tendyne Valve, and it's actually made right in Minnesota homegrown, in a town called Roseville, which is near St. Paul. It's got this D shape, which helps it orient towards a D-shaped anatomy of the mitral valve. It's got an outer and an inner frame. The outer frame is of varying sizes. The inner frame is one size. And then it has this tether. And that tether helps to anchor the valve as well as to promote its ingrowth into the mitral valve apparatus. And then on the end of that tether is a hemostatic pad that helps close the transapical wound, because this valve is placed using transapical puncture. And the nice thing about this valve, it's really quite incredible. There was a comment earlier about retrievable TAVR devices. This valve is fully retrievable, fully repositionable, even days after you put it in. If you put it in and a week later you decide that you don't like its position of performance, you can go right back to the thoracotomy, grab that tether, and pull it out. Or you can even snare it and move it to various portions to help get it out of the way of the LVOT. It's quite remarkable. So we had the pleasure of doing the first transcatheter TMVR in the United States, and we used this valve. This is back in April. So this is the entire team on the left-hand side. Obviously, it takes a village to do these complex procedures. Surgeons, interventionalists, echo, the entire, I think, pretty much the entire company was there. And on the right-hand side, I'm sorry, the slides are skipping ahead without me advancing. But here on the right-hand side, this is the patient. You can see there's quite a severe MR, as one can see here. So this is how it's done. You heard a little bit about XPlane Imaging before. So we do XPlane. And the reason why we do this is we want to be directly orthogonal to the mitral valve entrance. And so this is one view, and this is 90 degrees opposite. And if you look closely, that's my thumb. So I'm pushing on the apex. The surgeon has already cut down and done a thoracotomy. And I'm pushing on the apex to make sure that wherever we go with the puncture, that's going to be directly in line with the mitral valve or orifice. And it's usually not the true apex. It's usually posterior lateral to the true apex. In the top right-hand side, we then pass a wire across the valve, and you see this Fogarty balloon here. We pass that Fogarty balloon up and down to make sure we're not in the cords. And then on the lower left-hand side, sorry about this, lower left-hand side, you can see here the valve is being extruded in the left atrium, and you can see the D is oriented in the wrong place, so you simply just clockwise or counterclockwise rotate it. And do you mind just playing that lower right-hand panel for me? Is that possible at all? Or I can go back and go forward. Let's just go back and go forward here. In the lower right-hand side, you can see with the left atrial view, these leaflets are nice and open with the valve in place. And again, look at that D orientation towards the aorta. So in the upper left-hand side, this is what it looks like with the valve in place. The MR is gone. And on the upper right-hand side, we do an LV-gram. There's no paravalvular regurgitation. In the lower left-hand side, this is the final surgical wound. This is that apical hemostatic pad that's left in place. And then quite remarkably, we've been doing this since last April. Half of the patients we've done actually have had an improvement in LV function. And that's actually an abstract that's going to be presented at one of the surgical meetings coming up. And I think that's quite provocative, because historically in the med school and fellowship training, we've always been taught that the EF goes down after mitral valve replacement, but in this patients, half of them have actually had improvement. So these are the data that were presented at EuroPCR, and they're going to be updated hopefully at the ACC. Just suffice to say, there have been 19 patients done worldwide. We've done 9 of them. There have been no operative mortalities. The valve has been retrieved twice, and MR has been reduced to mild or trivial in all of the patients in whom the valve is left behind. So that's all I have for you, so thank you very much.